If you want to discover the global effects of the developmental compensatory patterns and how they impact neurology and postural dynamics, then you definitely need to keep watching. Hi there, I'm Dr. Krista, co-founder of the American Posture Institute and your host on the Chiropractic Pediatrics Virtual Summit. I'm so excited to introduce to you our next guest. Please meet Dr. Marty Rosen, President Emeritus of SOT Organization. He's been teaching SOT, sacro-occipital technique, for over 30 years. As the Pediatric Committee Chairman, he has spoken nationally, internationally, and been featured on top publications such as the American Chiropractor and Dynamic Chiropractic. Dr. Rosen, thank you so much for taking the time to join us on the Chiropractic Pediatrics Virtual Summit. Please say hello to everybody.
Hi, everybody, and Krista, thanks a lot for having me. I really appreciate this opportunity to share my passion with pediatrics and to get more people involved in taking care of children. So thanks again for giving me this time.
And you know what? That's what it's really all about. If we can help more chiropractors out there up-level their knowledge and their certainty, we can all help more children in general in our practices. And today we're really going to be diving in onto the neurology and the developmental aspects of postural dynamics. You guys know at the American Posture Institute, this is really within our wheelhouse, so I know I can't wait to learn more. Without further ado, I'm going to hand over the floor to Dr. Rosen. He's going to be sharing with us. I'll be taking notes. We're going to be learning together, and then we'll wrap up with a Q&A. Sound good?
Sounds great.
All right, take it away.
So the first thing I want to really talk about is the importance of pediatric care, especially in that first 2-year period. We always neglect that period of development. Well, always neglect, but in schools, we're not taught to deal with that particular level. Particularly the period from birth to age 2 is the most dynamic and important phase of postnatal development in humans. It is likely to be very critical in neurodevelopmental disorders, postural defects, and neuroplastic patterns. The pediatric growth pattern often suggests that the structural underpinnings of both the cognitive and motor development in early childhood, as well as the potential pathogenesis for neurodevelopmental disorders, occur in this period of time. Think about this. The brain reaches 80 to 90% of its adult volume by age 2. That is both gray and white matter. There's only a 15% increase in the next year. So by the first 2 years of life, 90% of your baseline foundation of the brain, its ability to function, its capacity is laid down in those first 2 years. Myelination will continue on, but the neuroplastic pathways occur. Matter of fact, the greatest part or the greatest time of synaptic development is 8 months postnatal. So you are laying down more pathways, creating more gray matter, creating more neurological pathways in those first 2 years than you ever will before. And it's going to be the basis and the foundation of your growth and developmental pattern. As you get going and as life goes on, and as more input is put in, then at the same time that this structural brain growth is occurring, there's an equally rapidly wide range of cognitive and motor functions. So your motor ability, the way you balance, the way you walk, the way you find yourself in space, occurs within that first 2 years. Any anomalies in this particular growth period or pattern may often result in developmental processes or limits as we get older on in life. They create compensatory patterns. Major Dujournette, who was one of my mentors and developed sacro-occipital technique, talked about the subluxation that occurs in his case, he talked about the first 7 years. And basically what we're talking about in pediatric is a subluxation that affects the duromeningeal system. So we're not talking about one bone on top of another, but it affects the entire duromeningeal system. Tension within the duromeningeal system greatly affects the cranial bone growth patterns, CSF fluid motion, and tension without the entire nervous system. So the spinal cord could be too tight or too loose, and we all know when we're talking about posture and things like forward head posture, that is often an issue with too much tension, not in the musculature, but in the underlying structure that is causing abnormal muscle firing. The other thing that I want to talk about and what's so important about the cranial development is the visual cortex. Most early postural developmental processes are occurred due to visual proprioceptive writing reflex, which is basically the visual cortex, which is located in the cerebellum. The cerebellum is so important. It is our mainframe computer that in that first period of life, it grows 240%. So think about that. We have this mainframe computer, we have a visual cortex, we have visual proprioceptive writing reflex that are going to determine how we hold ourselves in space. These cognitive regions of the brain, the cerebellum, also then eventually have reciprocal projections into other areas which are non-primary, things like the parietal, the frontal, and those association cortexes. So what happens is if information gets backed up in there, in that particular area, then what happens is it can't communicate with the rest of the brain. A perfect example of that is retained primal reflexes. What retained primal reflexes are fight or flight reflexes that are necessary in the first 2 years of life to protect ourselves, to deal with environmental stresses. What happens is as our visual cortex develops and then we get midbrain function, eventually we're supposed to get prefrontal cortex development to let us delineate what is safe and what is not safe. If there is a breakdown in that particular neurological sequela, then what happens is the prefrontal cortex doesn't kick in when it's supposed to, and the retained primal reflex keep us in a fight or flight state. So it changes postural dynamic. Kids who are toe walkers, kids with forward head postures, kids in guarding reflexes. Those retained primal reflexes affect the entire central nervous system because they keep it in a fight or flight state. If there is traumatization, and this has been found dozens of times, matter of fact, in 1992, the Journal of Manual Medicine talked about this. If there is trauma to the suboccipital structures, base of the brainstem, what chiropractors always talk about, C1, C2, and occiput, then that affects what's called the pre-programmed feedback loops. They are motor pre-programmed feedback loops. That's why during developmental processes, we hit certain developmental milestones. These pre-programmed loops fire at specific periods of time. If they don't fire correctly or we skip one of those developmental stages, we've set up a compensatory pattern. That compensatory pattern, because we're adaptive mechanisms, we will adapt to that compensatory pattern. We'll change. We will work around it. But the price for that is that later on, when there's additional stress, we have reduced capacity to adapt. So it lowers our threshold capacity, both neurologically, which is why so many kids are diagnosed with neurodevelopmental disorders around 3 and 4, even though the process has started earlier. Maybe they skipped crawling. Maybe they walked in a defensive mode. It changed it. Maybe they had a forward head posture. Maybe they were toe walkers. However the compensatory pattern showed up, later on, as more input is put in and the nervous system is called on to work harder, it breaks down. And then they get diagnosed with a disease type of process. So to sum this up, think about this. In the first year of life, your neurons are making 1,000 to 100,000 synapses, peaking at 8 months. Your brain grows 2.5 times in the first year of life. 101% increases in the first year with a 15% increase in volume in the second year. That's gray and white matter. The cerebellum grows 240%. By age 2, 80 to 90% of your adult volume is set. So think about this. As we integrate, the first 6 years of life is when we're going to integrate. What happens is we take that baseline and we start to use it. At first, we're just like a computer pouring information into ourselves. Once we have that information, over the next 6 years, we integrate that information. So the person you are at age 6, your mental capacities, your physiological capacities, your sensory systems are all developed by that age. That's who you are today, barring any severe traumas. So when you see a patient that comes into your office with all these postural distortion and you're trying to work from that level, it's a much deeper process. You have to get into that central nervous system and repattern those neurological processes. Exercises are helpful, but you can't exercise when there is aberrant neurological input. So you have to change that neurological input to create a new neurological pathway. That's basically what we're talking about. You have to understand that posture is largely maintained by reflex involuntary control, which means it's subconscious underpinnings that you created by that point in time. If you ever watch two people in your office walk, let's say a father and a son, all of a sudden you'll see the son at 3 or 4 years mimicking his father's posture. These are unconscious control patterns that he does, and these mechanisms are housed mostly within the head and neck region. That's where most of that proprioceptive and visual cortex is. So the visual and vestibular input, as well as joint input, are the major players in the regulation of straight posture, which is why chiropractic is so effective and so important. So let me just emphasize the importance of that visual cortex and that visual field. It does several things. It stabilizes the visual field for gaze stabilization. So when you're walking, we always try and aim our eyes at the horizon so we maintain a balanced posture, our head up as opposed to our head down. We don't want to look down when we're walking, though, of course, these days with texting, that's a whole different ballgame. But it also stabilizes the center of the massive head within the trunk and the feet. If our head stays straight and level, then we center our basically C2 over S2, and that maintains a balanced posture. Third, it minimizes external stress acting upon the head and trunk. For example, if you have a bad right knee and you start to lean to the right and you have to limp, it takes energy from your body's processes. If you have underlying neurological facilitative patterns that you're compensating for that you don't even know, one of the first things you'll notice is that there's a large fatigue factor. Probably one of the first things chiropractors notice when they adjust patients and their balance starts to come back and their postures change and their pelvis stabilizes, the first thing the patient will tell you is, I have more energy. They're not working as hard. There's a certain amount of energy allotted for your body to function under gravitational stresses. If that energy is sapped, or you have to use more of that energy, so let's say it's 25%. If you are compensated, you may have to use 40% of your daily body energy just to maintain yourself under gravitational stresses. And that's when the system breaks down, and that's when the system can adapt. So we have to understand that both the visual and vestibular systems are individually two of the most important postural reflexes. It's their constant integration that makes control of upright posture possible. And to come along with that, what I want to talk about is two things: the cervical spine and the cranium. So a lot of chiropractors don't do cranial adjusting or find it something outside of their particular parameters. But what I want to talk about is dealing with two things: the occiput, the sphenoidal, and its relationship to the cervical spine and the mechanics of the temporomandibular joint. Because when we're talking about infants, especially in this day and age, we see a lot of kids with tongue ties, nursing issues, sucking issues. Those are also important developmental aspects that change the mechanics of the cranium and also the cervical spine. The temporomandibular joint, abnormal temporomandibular joint motion in infants, including things like sucking and latching and swallowing, and in adults, obviously TMJ problems, focus muscular stress on the upper cervical spine, C1 and C2. They also change head posture. A posterior rotated mandible will pull the jaw back and rotate the head forward. An extruded mandible will do exactly the opposite, pull the head forward and extend the cervical spine. Either one of those changes the visual proprioceptive writing reflex and changes the mechanics in the cervical spine, constantly putting afferent input into the propria and nociceptors back in that particular area. So the thing that we look at when we're talking about the cranium is, I'm going to pull it up here, when we're talking about right here in the pediatric practice and adult practice, is this joint right here. It's called the sphenoidal joint. It is a synchondrosis joint, which means it is the most movable joint in the cranium, and it stays a synchondrosis joint for at least the first 26 years of life. The whole idea of this is the attachment and the changes in the dural system. So let's talk about pediatrics and then move on to adults. So the dural system attaches on the film terminal all the way down to the coccyx, comes all the way up, attaches strongly around C2, C3, comes in to the foramen magnum, then attaches into the cranium to a thing called the falx, the tentorium, and in the pediatric skull, because there is no sutural system, it actually comes out through the sutures of the skull and forms a periosteum of the cranial bone. So it is basically a tube that attaches all the way down from the coccyx all the way to the top of your head. At the same time, every single vertebrae, or every single nerve root, attaches to the dura at the dural ports as they exit. So this tube maintains tension within the nervous system. It also controls movement of cerebrospinal fluid. What makes it so important is this: neurological facilitation patterns in the pediatric practice are not compressive forces. They are traction forces. It's very hard to compress a nerve root in a pediatric spine because you don't have exostosis, ankylosis, and degenerative disc disease. But what you do have is abnormal tensions created by abnormal environmental and structural stresses. The forward head posture can actually stretch the spinal cord 5 to 7 centimeters, depending on how tall you are. And Alf Brigg, in Adverse Mechanical Tension in the Central Nervous System, said that traction of a nerve root causes immediate pathophysiological changes in the ability of that nerve root to transmit impulses. So think about this. This is what we're saying. If the dural system is under stress, which is what is the system that gets affected most in the pediatric practice, then that changes the entire tension on the central nervous system. The body will adapt. Those of you who take care of kids, most of the time when you see kids, especially young kids, preambulatory, that are coming in for care, when they are under stress, as long as they don't have any neuromuscular disease, when they tend to be tense, they tend to pull their head back or pull their head forward. I've asked this question dozens of times in my seminars, And the answer is they tend to pull their head back. They tend to extend backwards. Kids tend to do that. When you diaper them and try and pull their legs up, they'll arch their back. What is that? Why are they doing that? The reason for that is because their duromeningeal system is too tight. It's irritated. It's too tense. So what they're trying to do is basically bring their head close to the tailbone to shorten the tension in the duromeningeal system. Now think about that as they go through their developmental milestones. Think about the kid who starts to roll over, is able to sit up, and then when it comes to crawling, starts to crawl with one hip rotated up, right? You've seen that. I'm sure we've all seen that. Well, why is that? Because there's too much tension on one side. They can't relax the tension. So the quadratus lumborum, the erector spinae, they stay tight on that side. They can roll the hip up. If the sacral nutation is abnormal, it can create stress in the duromeningeal attachment at the pelvis, and will cause them to change their gait mechanism. If that is uncorrected, when they start to walk and stand, and especially when they start to walk, they will change their walking pattern to compensate for that. Maybe they'll pull one hip, maybe they'll rotate one leg, maybe they'll have external rotation. Whatever it is, they'll have compensation patterns. If it's really too tight, what happens is when the duromeningeal system goes into what we call flexion, when basically the occipital base goes anterior, it causes too much tension in the dura. And when it does that, it'll also track, all right, it'll end up tracking the occiput slightly anterior. When they stand up and the occiput slightly anterior, the visual cortex will force their eyes to track slightly down to compensate for that. So they will walk in a balanced state. You'll see those kids that are walking with their hands spread out or their feet 12. If they continue that to age 2, they will create compulsive neurological patterns that we see, postural dynamic changes, neurodevelopmental issues, all that because, again, they're not only are they not able to walk correctly, but they're not able to create brain lateralization. If they can't walk in a cross pattern, then they won't be able to lateralize their brain. So when they go into a situation like school, the lateralization process will be limited. And instead of taking information in like most of us do, through one side of our brain, process it, and then move it to the other side of the brain, they take all the information in like a fire hose. They can't process it. They can't segment it, so they get overwhelmed. And then we have our list of all those neurodevelopmental disorders, sensory processing, sensory integrative, ADHD, Asperger's. All of that is basically an inability for the brain to process information in a linear manner, and it gets overwhelmed. And when it gets overwhelmed, it either shuts down, which is one form of neurological developmental disorder, or it acts out and gets aggressive. Either one of those is the same parameter, the same stimulus that does that. So when we deal with pediatrics and when we're working with evaluating the spine, we also need to evaluate the cranium. For those of you who don't do cranial work, at the very least, you have to evaluate the relationship of the occipital condyle and atlas, because that is an area where the visual cortex can get too much afferent input, and the visual cortex can create compensatory patterns, which will change visual proprioceptive reflexes, which will change postural and structural developmental processes. The other thing that happens is if the curves of the spine are not formed right, if they don't go through their normal developmental processes and the curves of the spine do not form right, that will globally change the way the bone growth patterns occur. When the neurological processes underlying it create abnormal muscle tension, there's abnormal dural tension, the third thing that happens is a piezoelectric effect. If there is a loss of the normal cervical curve, instead of having resilience or flexibility in the cervical curve, what you'll get is a jamming or compression force on the vertebrae. And since the vertebrae are trabecular patterns, what happens is that creates what's called a piezoelectric effect. Dr. Pettibon talked about it many years ago, and basically the piezoelectric effect is a response to stimulus, mechanical stimulus, and it's based on Wolff's law. Basically, it says a deforming bone or a bone that has too much pressure will create a minute electrical current, a negative charge on the side of compression and a positive charge on the side of tension. That changes calcium deposition. So what we're talking about here is that calcium, which is a positive ion, will be attracted to the side of tension and pushed away from the side of compression, which will basically change bone malformation. So you're actually, every 7 years or so, we're redistributing bone development. If you have abnormal stresses, be they dural tension, postural stresses, or writing reflex stresses, it will actually mechanically change the electromagnetic field around the bones and change the way calcium is deposited in that system. So when you start to see a person with a scoliosis, or a person with a forward head posture, or a person with a high hip, and you take an x-ray and you see bone remodeling, that is a process that had started probably in their first 2 years of life, definitely by their first 6 years of life. And the only way to change that is change the biomechanics and the neurology. You have to change the neurology so that they get new afferent pathways so that they can readapt under those gravitational stresses and allow for future bone remodeling to occur. Most of the people, matter of fact, all of the people we see in our offices who are over 2 or let's say even 6 years old, give you a little bit of a leeway there, what we're seeing is a massive compensations. We are not seeing the causative factors. And the goal for chiropractic should be to peel away the layers to find the primary subluxation. Duchenet said it a long time ago, if a primary subluxation is left uncorrected, that person and that person's nervous system will adapt and compensate for that primary subluxation for the rest of their lives. So it is extremely, extremely important that we learn to evaluate not only the structural aspects, the neurological aspects, and the neuromechanics of a nervous system, especially when we're dealing with children, because what we really want in chiropractic, what we always say, is we want to find the cause of the problem. And that's the whole idea. So when we're dealing with postural issues, we always should check visual cortex function, check for nystagmoid movement, convergence, writing reflexes, check for primary reflex, retained primary reflexes, laterality. All that tells us that the nervous system is functioning correctly. You can be working an uphill battle. A person's not lateralized, not using a dominant hemisphere, and trying to maintain their postural dynamics. Every time they talk to them, their head's going to be in a head tilt because they're going to be looking at a way that they have compensated for. And you can adjust their atlas occiput all you want. If the visual cortex is not stimulated or working right, every time you talk to them, they're going to be looking that way. So the idea behind what we're looking at here in this process is the key continuities. The key continuities are balancing the duromeningeal system, because in the pediatric practice, that is really what we're dealing with. We're dealing with duromeningeal stresses and tension. We're not dealing with structural anomalies yet. We don't have joint fixation. The only way you get joint fixation in pediatric practice is what we call positive muscle control, which means aberrant afferent input coming from someone else, calling muscle compensation. So we need to find out where that afferent input is coming in, what proprioceptors, what nociceptors are being fired, causing that compensatory pattern. So we're dealing with that duromeningeal system. The other thing about it, which I only have a minute or two, but what I want to talk about is just CSF quickly. The motion of CSF has been found to be paramount in the health of individuals. It is not only the lymphatic system for the central nervous system, but a study in 2017 found that kids ages 6 to 12 that had too much CSF on MRIs in their brain at that age, if it stayed after age 1, they had a 70% higher chance of becoming autistic by age 2 by increased CSF pressure. So, kind of to sum things up a little bit for you, just to give you my little hitting or talking points that I was talking about. First, I want to say the postural patterns and baseline functional parameters become set by age 2. That is when the greatest synaptic development occurs in that 8-month period of time. Full integration by age 6. Uncorrected neurological patterns become a primary source of stimulus through life. Compensatory patterns lower the adaptive thresholds and often build on each other, so you have a massive compensatory patterns when you see a person at 20, 30, or 40. Early TMJ issues like nursing, latching, etc. Will put stress on C1 and C2, create recurring subluxation patterns and muscle splinting in the upper cervical spine. The occiput and senobasal movement and position affect all the cranial nerves, all 12 cranial nerves, and they also affect the visual vestibular cortex through traction and can facilitate retention of primary reflexes by inhibiting proper cortical function. And the truth and the fact and the way to stop this is early detection and correction is the best approach, not just the model of repair. Thanks for giving me your time.
Yes, Dr. Rosen, oh my goodness, thank you so much for sharing this expertise with us. I was over here just writing so many notes, and I'd love to do a quick summary, and if you don't mind just kind of filling in any gaps that we had.
No.
I really believe in hearing the information a couple of times, and so that we can really take this information and implement. For all of our listeners, you guys know that I say all the time, it's not knowledge that's power. It's the implementation of that knowledge that helps your patients have those powerful transformational breakthroughs. And we're talking specifically about the pediatric patient in this case. So I have 2 pages of notes. I'm going to go through it really quickly, and then feel free to fill in anything that I might have missed. So we talked about the first 2 years of life being that critical period and how posture is defined in that first 2 years of life. 80% of structural brain development is the foundation, occurs within that first 2 years. 8 months postnatal is the time of the most synapses occurring within the brain. And this is the development of the gray and the white matter. Dysfunction in the first 2 years leads to ongoing compensations that we continue to see throughout the developmental periods and then later into adulthood as well, if never corrected. And then you talked about the visual cortex and the role of visual cortex in the cerebellum and visual proprioceptive writing reflex of how we hold ourselves upright in space. And it allows us to stabilize our gaze. So instead of looking down at our cell phone while walking, we're able to actually keep our eyes up while moving our body and still balance our body over our small base of support, which is our feet. And then those underlying neurologic factors leads to fatigue. So if we have a limp, for example, you mentioned a compensatory postural distortion pattern, such as limping, we're actually using more energy because we're off balanced. And so you mentioned, and I thought this was such a great example, that when you help your patients get into proper alignment, they go, I suddenly have more energy. And that's one of the things that they get as a byproduct of being in proper alignment, because they're no longer using that excessive energy to hold their body upright from an unbalanced perspective.
Right.
A really great point. Retain primal reflexes. So we should go from primal reflexes that help us, as infants, we should be scared of certain things. We need to have those startle reflexes, for example. However, we should move into postural reflexes. And if we don't, and if we have retained primal reflexes, this shows up as forward head posture, toe walkers. Prefrontal cortex development is inhibited associated with the retained primal reflexes. And then you talked about motor pre-programmed feedback loops. So if these don't fire correctly, we develop those compensatory patterns. And then when you talked about the cervical and cranial aspects, I just have to go through a couple points here because this was just too good and everybody needs to hear it twice. The occipital condyle, so when this is off, this can impact the visual cortex. You mentioned that as that shifts the position, that we could be looking down. And as we continue to look down while walking, then we're constantly, our visual cortex is not firing in the appropriate manner, creating disorientation. And then the spinobasilar. So it's movable. It's a synchondrosis joint, meaning that we can move it. And so this, for chiropractors, obviously is a huge advantage because we love movement, right? And when we can move something, we can create changes of the position as well as provide that proprioception with the movement. And so you talked about dural meningeal system comes into the foramen magnum and attaches all the way down to the coccyx, so from coccyx to cranium. And when there's abnormal tension, such as forward head posture, this can actually stretch the spinal cord. And how we can see that if the infant is presenting where they're going into an extension, they're extending their spine, this is to actually relieve or reduce the amount of tension in that dural meningeal position. System, yeah. And then starting to crawl. So when the dural meningeal system is off, you mentioned that, for example, going into extension, but also it can have a difference in the hip position. And so when you start to crawl, maybe you have one hip up, and then this is creating sacral stress that then continues, if it's never corrected, to then impact gait patterns moving forward. And if we have impacted gait, then we have poor brain lateralization, which, come first grade, second grade, third grade, shows up as a learning disorder that then receives that label of, let's say, ADHD, right? And we could have had a tremendous impact on their development from the beginning to prevent this from impacting their brain lateralization. Absolutely. And then with TMJ, abnormal motion affects sucking, latching, swallowing, and can cause forward head posture and changes of C1, C2. And then you wrapped it up perfectly by saying we need to balance the dural meningeal system, CSF motion, that's the lymphatic system of the central nervous system. Too much buildup can lead to autism. I think you said 70% of children.
Chance of diagnosing, or a higher chance of getting autism if you have too much CSF in your cranium by age 2.
I mean, that right there is just, that's into
massive.
Perspective. Yeah, puts it into perspective. And posture set by age 2, full integration by age 6, compensatory patterns, lower the threshold and build on each other. So if we want to make biomechanical changes, we need to work with the neurology in order to stimulate the visual cortex, visual system, the vestibular system, and of course, those joint proprioceptors. What did I miss? I learned so much from your presentation.
Nothing. That was awesome. That was great. If this was your PhD test, I think you got your license.
Well, I appreciate that.
That was great.
No,
it was great.
What I love about this is it's so practical. And like I said, for me, I always need to hear the information twice if I want to take something and go use it.
Absolutely.
And when we start talking about neurology, I think it's easy for a lot of chiropractors to kind of get wrapped up in the weeds of, the name of this or how that attaches to
That's not
this.
important.
But when we think about how this shows up, like, for example, the example of, we have more fatigue if our bodies aren't balanced.
Right.
The babies are going into extension if they have too much tension in that system.
Exactly.
And then if we have changes the hip position, that impacts their crawling patterns, and then that impacts their gait patterns. And then later in life, this can show up as what we would see as a learning disability.
Yeah.
Can you talk to me when a patient comes in the first 2 years of life, and I know this is a very general question and it's always going to be patient specific, but you have mom who brings in their infant, and let's say they're 1 year old, 1 to 1.5. They're in that first 2 years of life. What does a typical, like a standard treatment protocol look like in terms of how many visits, how often you're seeing the baby, and how you're communicating this to mom of how often she should be bringing in the child within that?
So when I do I don't adjust on the first visit. I always do my exam. I do a little brief vignette for the patient on the exam, and then I tell them to come back for the report of findings. I do that for 2 reasons. One, on the report of findings, I check my positive indicators to make sure they're still there, because I adjust according to a pattern. So to create a pattern, I need at least 2 visits. So when the parent comes in, let's say it's a 1-year-old, let's say, look, we found this specific pattern in your child's nervous system. It depends, the conversation depends on if it's a patient of mine who brought their child in, or if it's someone who found me on the internet. So obviously, if I'm found on the internet, it's a little longer conversation about what we're trying to do. But I basically lay down how the neuromeningeal system creates tension in the central nervous system, and that one of some of the issues that your child is suffering from or having is because of there's aberrant tension in that neuromeningeal system. So we have a two-phase process. We want to change the pattern, and we also want to facilitate a more normal pattern. So what I tell them is the process may take 4 to 6 months. The visit frequency will change depending on how that pattern changes. I start almost all kids at twice a week. And then after 3 weeks, I do a progress exam. So the conversation may be, look, what we need to do is make a positive input, what's the word I'm looking for? Consistently over the next 6 to 8 weeks to start to change that pattern. So I'm going to start your child on a twice a week regime of adjustments. At the end of 3 weeks, we do a reevaluation. Depending on how much that pattern has changed, I'll either keep your child on that twice a week for the next 3 weeks before we do the re-exam at 6 weeks, or if they're stabilizing, I may change that visit frequency. So I don't lay out the whole program. So after 3 weeks, I do a progress exam. If Johnny's doing great, not symptomatically, my neurological pattern, I'll change his visit frequency. If he's not, regardless even if his symptoms are gone, I'll keep that pattern. At the end of 6 weeks, we do a re-exam. And the reason for that is because now that the internet is out there, we get a lot of people who come in for symptomatic care, as opposed to when I first started practicing 37 years ago, patients brought their kids in. So at the end of that period of time, most of the time, the symptomatology that the patient came in with is gone, because if it's not, the patient's probably gone. And then I'll give them the option to say, look, we've changed, Johnny's neurological pattern. Now we need to do things. Make sure that that pattern is really not coming back, and to help facilitate a more normal pattern. So now I want to see Johnny once a week for another month, or every 2 weeks, whatever the objective finding state. And I already laid down that it's going to take 4 to 6 months. And somewhere in that conversation, say, look, when we get through this 6 month period of time, we've reestablished a normal neurological pattern, and then we can talk to you if you want to do some kind of maintenance care. So the conversation is definitely more difficult these days, because so many people get us, especially when they, Google me for symptomatology. So we have to try and change that for them to make that shift. So it's a little bit harder, but that's kind of how the conversation is. So I don't give them exact number of visits. I give them number of visits, and I show them that it's based on my objective findings, not whether Johnny's not throwing up or his ear infection went away or whatever, or these nursing data, whatever that issue is.
Yes.
That's pretty much the conversation.
Nice. And those two key words right there is objective findings, because if you can show mom something pre and post, she understands that a change has taken place. Because if not, mom's only understanding is symptomatology. And so we need to show those objective findings so that we can show pre and post what's happening. Are we there yet? Have we made progress? But we need to get from here to here, and we can show that objectively. I love that. And that's
I'm just wanting to interrupt for a minute, because the other thing that's amazing about that piece is that, so let's say a parent comes in because they have latching issues. And the latching issue goes away, and after 3 weeks, I'll do my progress exam, and I'll go over the findings. And I goes, I never told you this, but he never pooped. He only pooped like once every week. It was,
Right.
and now his poops are normal.
Yeah.
So they'll always give you another input that helps them, gives them that aha moment. Oh wow, this is global. So, mouth and butt.
Sure.
It's like that kind of thing. They make that connection.
Yeah.
Yeah.
Yeah. And when they have those light bulb moments too, it's really powerful for them because they start to make that functional connection and that neurologic connection, not just the symptomatology connection.
Exactly.
I love that. Dr. Rosen, I just, again, want to say thank you so much for sharing your expertise with us and acknowledge you and just let you know that this information is so valuable. Just what we've learned today on our presentation is so useful. Where can all of our viewers learn more about you and your seminars and continue to follow this process?
Okay, so a couple of things. One is my website is drmartinrosen.com. That's my professional website. It has all our seminars that we teach. It also has all our books and all our DVDs. So we have DVDs for cranial work, spinal work, reflex work. And the other website, if you want to get some information about my office, is Wellesley, WELLESLEY, Chiro.com. And that's my office website. But for doctors, it's Dr. Martin Rosen. And as a giveaway, what we're going to be doing for this promo is we're giving away this DVD. 2 years ago, I did a masterclass online, 30 hours, and we redid all the DVDs from that. So these are all redone. And this one is training evaluation procedures, because I think that's probably one of the biggest weaknesses in the chiropractic profession. So when we set up this whole program, there'll be a link, and you just click on the link, and that will be the giveaway for anybody who's interested to start to learn this process and expand their practice.
Oh my goodness. Thank you so much for your kind generosity. What an amazing free gift. I can't wait to dive in and learn more. I know we've just gotten started today, and I'm already excited to learn more about cranial work. So thank you again for your generosity of sharing that with us.
My pleasure.
Dr. Rosen, thank you for your time. And to all of our viewers, I just want to say thank you to all of you and acknowledge you for being here and continuing your education to always learn more about special populations within chiropractic, in this case specifically the pediatric patient. Because when we work together to up-level the knowledge and education that we all have as chiropractors, we can ultimately help more children. And that's the purpose and the mission of the Chiropractic Pediatrics Virtual Summit. I'm Dr. Krista, founder of the American Posture Institute. I want to say thank you to Dr. Rosen, thank you to all of our viewers, and remind you to join us in the next session where we'll be continuing the conversation on chiropractic pediatrics. Dr. Rosen, thank you again so much for being here with us today.